Hi, everyone. I'm Liz Whitehead, Managing Editor of Events at U.S. News and World Report. Welcome to today's webinar on how health systems can alleviate the nursing crisis. Today's event is part of our ongoing Healthcare of Tomorrow virtual event series. You can learn more about today's speakers and see videos from other sessions we posted at usnews.com/healthcare of tomorrow. We are recording video of today's conversation as well as simulcasting on the U.S. News Facebook, LinkedIn, and YouTube channels. One final note, we encourage audience questions and invite you to type them into the Q&A feature on your screen. I will try to give voice to some of these as time allows during the panel discussion. Now, I'd like to welcome our outstanding panel. With us today are Dr. Iman Abuzaid, CEO and co-founder of Incredible Health, Suzanne Sue Algieri, Associate Chief Nurse, Massachusetts General Hospital, Dr. Ernest Grant, past president of the American Nurses Association and an adjunct associate professor at the UNC Chapel Hill School of Nursing, and Dr. Gail Vizella, senior vice president and chief nurse executive at Houston Methodist Hospital. Thank you all for joining us. Now let's get into the discussion. I'd like to ask our panelists to first help lay out some of the drivers of the nursing crisis. Can I start with you, Iman? There's been a steady drumbeat in the news about nationwide staff shortages, a burned out workforce, and a level of discontent among nurses that has led to strikes at some institutions. At Incredible Health, you're connected to some 650 hospitals and healthcare systems around the country. From that perspective, can you share some of the data to help explain how did we get to this point? And did COVID worsen the problem or simply throw it into greater relief?
Yeah, absolutely. So essentially what we're all dealing with is the US population is growing and it's aging, which is putting more and more demand on the US healthcare system. But we as a country have not done an amazing job increasing the supply of healthcare workers, including nurses, to continue meeting that demand. This huge, supply demand shortage has resulted in one of the biggest labor shortages we have in the country. In fact, nursing is the biggest labor shortage in the US today. And it's a trend that has started long before COVID and will continue, it's projected to continue even after COVID. COVID in particular was a demand shock, that's for sure, and sort of exacerbated some of the issues that already existed. But we were having, challenges long before COVID as well. More specifically, we're on track to be 1 million nurses short by the end of this year, which is a huge shortage gap. And then we're also seeing 21% turnover annually. That is the highest it's ever been in the history of US healthcare. Nursing turnover has increased by 2% in the last 2 years alone, which is a very large increase. We're also seeing that the labor costs are increasing. So it used to be that, so roughly about 50% of revenue is spent on labor. So it's not just the travel nurse or premium labor, but even the cost of our permanent workers is increasing because of the huge labor supply shortage. And then the days to fill a permanent nurse position, particularly one that's specialized, is currently at 89 days. So it's taking over 3 months on average to fill a specialized nurse role in an acute care hospital.
Wow. Ernest, we sometimes skirt over this. We talk about this big and serious problem, but can you just lay out what are the practical and concrete harms to care delivery if we don't retain an adequate supply of nurses? Actually, we don't have an adequate supply right now at hospitals and healthcare systems. What are the harms?
Certainly, but I'd like to add to Aman's comment, if I may, for just a quick second. This predicted shortage started probably about 15, maybe 20 years ago. And I agree with her that it's just poor planning on the part of not only schools of nursing, but, as far as getting students in, but, the Department of Labor, hospital administrators and et cetera, planning for the retirement of the baby boomers and, et cetera, that will be coming along. And of course, the specialization of nursing too, is a lot of people have opted to leave the bedside to specialize. And, that too is something to factor into that. But to get to your question as to, what is some of the practical harms to care delivery? Well, obviously, first of all, there's going to be a reduction in services that may be offered, because if you don't have enough staff, you've got to weigh, where can we either continue to cut corners or, services that a facility may offer and still have enough adequate staff to provide the expert care that's going to be there. Obviously, less staff also means that you're going to have overworked staff, which means that we've got to be concerned about eventually the potential of omission or commission of errors that could possibly occur as staff is constantly asked to work overtime quite a bit also. And of course, the other things we need to think about, the biggest harm, if you will, is that it's going to be the consumer who's going to be impacted, because they are expected to come to a hospital or a long-term care facility or even a clinic to get the same level of care that they envision in their mind should be there, and it's not there. And as a result, they're going to suffer, because in some cases, things that could be easily avoided or picked up on because of how overworked staff may be, or things they may get overlooked, so to speak. And so it is going to be harmful to the consumer when the services that they are expecting is not going to particularly be there.
Gail, feel free to pick up on any of Iman's or Ernest's points. Can you also just briefly sketch out the challenge of trying to manage some of these issues with the multi-generational workforce? What are some of the differences that you have to grasp, so that when we later in the conversation we'll get into recruitment and retention strategies, but what do you have to think about? How are the goals different for these different nurses? How are their needs different?
Yes, thank you. Just as Iman and Ernest mentioned, it's certainly a time of crisis in nursing. And that's the gravity of what we are all dealing with as hospital leaders, as nursing leaders, is how do we deal with this crisis? As Ernest mentioned, the shortage of nurses has been for quite a long time. Certainly, we lost a lot of clinical expertise throughout the pandemic of that most tenured group of nurses, which hit us all hard. I mean, as nurses and nursing leaders, we live in reality. We have to adapt and move forward. And I think that the good part, if there is a good part in a crisis, which I believe there always is it allows us to look carefully at the work of the nurse. So, and we have a spotlight nationally. People have seen, thanks to the great efforts of many people on this phone call, people have seen the value of the nurse. So we are nationally getting asked now, what can we do to help with the nursing shortage? And so I think we have to be strong, articulate leaders to say, what is it that we need? What do we need nationally with policies and programmatic growth? What do we need from hospital leadership in the gamut in between that? And I think we can also go back to what did we want when we became a nurse? What did we want to do? We wanted to listen to patients. We wanted to care for patients at the most vulnerable time. And unfortunately, over the years, we have been added on tasks that have nothing to do with the core essence of being a nurse. And so now, as we ask, well, what is it that a nurse should do? I think we, as listening to bedside staff and really studying what's the actual work of a nurse, and the tasks that no longer need to be done by a nurse, we need to partner with our hospital leaders to say, well, who else or what else can do that task? Is it innovation? Is it phlebotomists? Because everybody now sees that value of a nurse. And then as far as the multi-generational aspect, again, I think you can say, well, gosh, that's a struggle. 5 generations of nurses at the bedside or in organizations can be a challenge. But also, I think if we form some team of teams for work, for example, here at Houston Methodist, we formed an awards committee. And we made sure it was representative of the nurses that complement our system. And then they choose who receives from applicants, who receives that specific award. And really, each generation has their own view of that. But if they can come together collectively and make those decisions, it actually, I think, is a good representation of what probably nationally we should do beyond nursing. But I think it is an opportunity for us also to lead the way and to showcase what we do in nursing to lead through a crisis, and to reform nursing to what we actually think it is at its core.
Thank you, Gail. And you raised some points that I'd like to get into later about how we, how work at the bedside is rethought and ways to do that effectively. So we're going to definitely come back to that. Sue, do you want to pick up on some of these points?
Sure. I mean, excellent points by my colleagues. I think one thing that I would add is that our nurses want to be heard. And so I think one of the most important things that we've done recently at MGH is embarked on our strategic plan. And part of that is really looking at retention. So part of this work has been to listen to what our staff nurses are what they want, what are they interested in, because they want to feel that they're valued and they want to feel that they're respected, but they also want to know that they have our support and advocacy. So we've done a number of different focus groups to really understand what's important to nurses. And part of it's the flexible scheduling, understanding what helps them to have an appropriate work kind of balance, but also their balance at home. There's so many competing demands between, family, school, et cetera, that we need to be sure that we're looking at this as leaders from both sides of it. So that when our nurses are here at work, they know that they are valued, that they have the support of their leadership to have the things that they need at the bedside to be able to deliver the care. Some of the things that Gail has expressed is in earnest, and I'm in as well, trying to make sure that we're not bringing things to nurses that others can do. We really want to make sure that they're providing care at the top of their license and doing the things that are important to quality patient care. So providing that type of environment is important. We have a couple of ways that we hear signals within MGH, and that's through a few of the surveys that we do. One is a staff perception survey, and we give this to our nurses. And we look at it year to year, right? So what are we looking at year to year for differences? Are there signals? Are there things that we need to pivot to do differently to be able to support our nurses at the bedside? Then organizationally, we also do a unit culture survey. And this helps us to understand whether or not there's issues with quality of care, whether there's issues with teams working together within the unit, across units, and all of this helps to provide a better work environment for our nurses. So that's just another way that we can do this.
Thank you. And you've all raised really important points that I would like to talk about more in detail as we move forward. Thank you. Actually, let's talk for a second about attracting and hiring nurses. Let's start with new nurses. Iman, can I ask you to talk about what are the biggest factors for nurses, attracting nursing school graduates? Is it salary, reputation, culture? This is, we're going to get into experienced nurses, but I'm going to start with new nurses. Do they pay attention to culture, career growth? What are the kinds of hiring approaches work best for them?
Yeah, absolutely. So I agree with what Gail was saying earlier, that this is actually a time for like hope and optimism, because, market forces are essentially like driving all of us to look at all this data more carefully and to come up with strategies and tactics that work, given the current challenges that we have. We started Incredible Health 5 years ago, and we discovered, one of the areas we discovered is the processes, the tools, the technology that hospitals and health systems use to hire nurses hasn't really changed in 20 years. It's post a job and hope it all works out, right? And that's just not in a situation like this with huge supply demand imbalances. That's just simply not enough, right? And really need more innovative ways to approach that. For new graduate nurses in particular, which is a subset of nurses that we support as well. We've had to do quite a bit of research on this cohort. This cohort, for the most part, is Gen Z. Of course, there's other generations that are new graduate nurses too, but mostly it's Gen Z. And there were a few insights that we figured out in our survey data and our analysis too. First, new graduate nurses really care about onboarding and training. And they report, 70% of them report feeling overloaded and overwhelmed during onboarding. 41% report that they're going to choose an employer based on how good their on-the-job training is. So that's one area where we've seen more hospitals invest more heavily into their new graduate programs, and that is definitely paying off in attracting new grads and retaining them after the fact too. And then the second area that's different for Gen Z compared to some of the other generations is their desire to move up in their careers and to specialize as quickly as possible. Historically, nurses were, it was fine to stay in the med surg units for many, many years before you move into the into other units. But no, new graduate nurses after year one, they're like, okay, I want to move into labor and delivery. I want to move into the OR, and so they just like a very strong desire, very strong ambition to progress more rapidly. And so again, employers have had to react and adapt to that as well.
Sue, can you pick up on this? MGH does a lot with nursing schools. Can you talk about how you are trying to strengthen the pipeline to new nurses? What initiatives have helped you and why?
Sure. We actually just had the same conversation with our talent acquisition team prior to this meeting. But fortunately, the city of Boston has a lot of wonderful nursing schools and programs, both within the city and the surrounding areas. So MGH has a clinical affiliation program. So we are looking for schools to come to MGH to do their clinical rotations. So currently we have pretty much annually about 3,000 students in 32 different nursing programs that come to MGH. And they will do their clinical placements on a variety of different units. It could be our med surg units. It could also be some of our specialty units. And they have these rotations through, it could be on the day shift, evening shift, weekends. So we offer a lot of opportunities. We have a couple of specialized programs that we do offer as well. We have a strong affiliation with the Institute of Health Professions here in Boston. And we also do a lot of work with the University of Massachusetts at Boston. So two specific programs. So one is the dedicated education unit. We have this on 2 of our units, and essentially it helps to start a student off in their junior year on a specific unit, and they have a dedicated preceptor who's on the unit, but they're considered to be the clinical faculty of UMass Boston. They're supported by the faculty at UMass Boston to help bring these students through their clinical rotations. But what's great about it is by starting in their junior year, by the time they come to their senior year and they do their one-on-one senior practicum, they've already been on that unit. They already know the staff. They're progressing through their clinical to really become autonomous and really prepared for graduation. And that's where I'm spoke to the places that have like a transition to practice program. That's something that we have here at MGH as well. And that's really critical to starting new graduate nurses off in feeling like they have the support that they need, the education behind what they need, and really helping them to transition from school. MGH also offers the one-on-one practicums that I mentioned within the DEU, but also to other nursing programs as well. And that's been very successful. They're great to have these pipeline programs in which you really start to have the conversation early within a student's senior year to say, hey, we'd really love to have you come on board here with us. And let's see if we can figure out if this is a good fit for you, because we would really love to have you join our team. Things have changed, I think, through the years, and we really have to start focusing in on this much earlier in a nursing student's career to encourage them to really start to think about where they want to be once they graduate. And, we hope they make the choice to come to MGH.
Gail, Houston Methodist has also been working hard to develop, broaden its relationships with nursing schools. Can you describe what you're doing now?
Sure. For sure, I'm going to take back some of Suzanne's ideas as well. Certainly, they do lots of intensive programs that certainly we can capture here. We too have, struggled with it. A lot of times students come to us, but we as nursing hospital leaders don't go to them. And so it becomes very siloed. And I think that was exacerbated during the pandemic when they couldn't do clinicals. So we saw nurses coming onboarding with a lot of anxiety and fear of entering their nursing career, which we do not want. And so again, I think in that spirit of you can do things totally differently now because people are much more open to partnering differently. Is we here at Houston Methodist have a lot of schools of nursing as well in the Houston area, in particular in our medical center. And so we have embedded some of our folks that are part of our centralized education team to spend time each week within the schools of nursing. And not just with juniors and seniors, but to meet freshmen, sophomores as they start their careers. Because I think, Aman, to your point of people want to move fast.
Yes.
So the days of kind of saying you have to do your time on med surg units, if that's not what they want, then, well, what if we did specialized training earlier or had them do intensive practicums or clinicals during their time in school to see if we could really get them to where they want to be sooner, with less anxiety, less stress. And so we're really trying to look at different programs in order to accomplish that. But certainly to offer to the schools of nursing, as we know, there's that faculty shortage. So if they do have gaps and can't take more students, what we're trying to do here at Houston Methodist is to see where we can partner to maybe help support those didactics as well, and form those partnerships. Some of it we get donor money for in order to have some of our staff go over there and their pay supplemented. So just trying to look at different avenues. Certainly, again, there's a lot of community support to help nursing. And if we can try different programs for that partnership, I think it'll, it's definitely good for our students. I think the transition to practice will be hopefully smoother. And then, of course, better care of a patient. It works for everyone.
Ernie, can we draw on your current experience as a nursing faculty member, besides former head of the ANA and RN yourself? What do you think we need to do? What haven't we touched on? Or do you want to reinforce some of the points of the other panelists?
Thank you, Liz. I'd like to reinforce some of the points as well, and then offer some other things. Obviously, whatever we can do to decrease the stress that the student may be undergoing. If they're worried about, finances and things like that, obviously having more monies available, scholarships, things of this sort. I think also increased use of the technology. Every nursing school now has a, wonderful simulation lab, which is really great. And I think it's important that we continue to encourage the student to not only just go there during your assignment, if you will, that may be there, but also on their own, go and, make an appointment with the simulation lab instructors or whatever, to have some practice sessions that will increase their critical thinking skills, because that's what's so important when, that transition to care is, you're applying theory into practice, but this is a great way to, to start honing those skills, while they are still students, and they could have faculty there or even retired faculty to serve as mentors to help them, get over that hunch there. Another thing that schools of nursing are doing, obviously, we're approaching the federal government, obviously, about some additional funding, because one of the, the biggest problems is that there's not enough faculty to, to help with the, if we want to increase the enrollment of students and et cetera, you got to have qualified faculty. And on average is I believe the age of the average nurse at the bedside is about 54. So you can imagine what the age of faculty may be at that particular time. So I'm going to get some emails, I know, from that statement. But we do need to have funds set aside to train new faculty. As Gail and Suzanne mentioned, some of their staff is helping, to serve as faculty. So, put funds aside that will help to give them, some workshops or things like that would help their skills as well to join in to ensure that, the points that you want to get across are taught, and there's alignment with what is taught in school and also what is taught in the clinical practice setting as well. So we need to, make certain that, the funding that the federal government or even the state government may be setting aside, that it is going to be used to, help better that particular situation. And, as I mentioned, offering scholarships for people who want to go back to school to be faculty as well is a great opportunity also, because you're going to get such a great return on your dollar when you, you make that investment. It's someone who is going to remain, in and around the areas that they are familiar with or within your state. And, again, they're familiar with, with the school that they may be associated with, and the hospital or the other, facilities that they may be where clinicals are done. They're going to be familiar with that as well. So it makes for a really good, nice, seamless transition, if you will, to, take that approach.
Thank you. Those are all wonderful points. So bringing new nurses into the profession is going to partially help the problem, but unless we can keep experienced nurses in the profession and not, either retire or take jobs in other sectors, we're going to have a huge problem that's going to remain unfixed. Iman, can you talk about what your research shows about the most important factors determining whether experienced nurses stay or leave? And obviously we care most about what do we need to do to get them to stay? What are the top factors?
Yeah, absolutely. So we have, there's 1 in 4 nurses in the US uses Incredible Health to manage their career. So we're talking to close to 700,000 nurses are using the platform for a variety of reasons. It could be the access to the 700 hospitals we work with, including 75% of the top ranked ones, or the fact that the marketplace itself means that the employers are applying to the nurse instead of the nurses applying to them. One of the unique things about our platform is that when you're signing up as a nurse and creating your profile, is that you're asked, like, what is it? Why are you considering changing jobs? Like, what's happening? And this data is coming in on a continuous basis. It turns out that the reasons why they're changing jobs is not always aligned with what we hear from the CNOs and CHROs that we work with. Not always, right? So the HR leaders and nursing leaders, and again, I'm generalizing, of course, are very clear on burnout and compensation. But there's also like some other critical factors that have to get addressed too. We're seeing by far the number one reason why nurses are considering leaving the job is because they're looking for more career advancement. And that could mean a range of things. It can mean I want to specialize more. I want more cross training. I want to go into leadership, whatever it is. The second most common reason that's selected is I'm looking for a more flexible schedule. The days of 3 days a week, 12-hour shifts full time, and that being the main and the only option is over, and they are looking for more flexible scheduling. The third most common is something to do with geography. Either they're trying to shorten their commute time or they're relocating from a different location to a different location altogether. Everybody understands the movement that happens among travel nurses, but even among permanent experienced nurses, there is a huge amount of geographic mobility throughout the US. And then the fourth is pay. And so some leaders perceive pay as being at the top, but it's actually not. Career advancement is actually the top reason why nurses are, considering leaving a role.
Well, I'd like to hit all those points. So, Iman, let me just ask you to just say 1 or 2 more sentences on career planning.
Sure.
What makes an effective plan? And then I'd like to go to the rest of the panel to talk about career planning, cross-training, et cetera.
Yeah, absolutely. So we're finding that the HR leaders and nursing leaders that are essentially crafting a strategy and set of tactics to tackle these, so career advancement, flexible scheduling, so on, are really able to retain more, and they're able to hire more too. For career advancement, that can mean a range of things to a nurse, right? So that can mean, a new graduate looking for a new graduate program. It could mean someone who's already in a graduate program and looking to specialize further. It can mean expanding skills in a certain specialty area. It can include cross training. And then it can also include, a desire to move into management too. So it is like a whole suite of items. And what probably one of the more, I'm sure we'll go into it in terms of the many tactics that we can put in place for career advancement. So of course there's the official programming, but there's also, just simply documenting the career mobility plans of a nurse. At day 90 from their start date, is it documented how their career is going to evolve at the health system? Is that very clear to the nurse and the nurse's manager about how they're going to advance? And so these are all, tactics that really improve retention too.
That's great. All right. So Gail, I know you have a lot to add on this. Actually, Gail, can you start first and talk about how you approach career planning and cross-training with your nurses?
Sure. And I think, again, Iman, you're spot on, it's something you have to look at from very early on. And we are used to traditionally in nursing using templates even for that career planning. So it's a tool that managers pull out usually at evaluation time to say, okay, well, what's your career? And it's fine to use a template. It's just the questions behind that template. So a lot of times I think as frontline nursing leaders, our nurse managers, we put a lot of pressure on those frontline leaders to keep and retain nurses. And so it's almost counterintuitive a little bit to career planning, because if that nurse says, well, gee, I would like to go work in the operating room, we're like, but wait, we've trained you here. You need to stay with us. And so I think accepting for our nurse managers, first off, that it's okay. We hope to retain people within our system, that they feel like they're working in a place that has a good culture and really a lot of career advancement. That would be the best part. But we don't have to kind of lock them into where they start. Most careers, you don't do that. And then I think starting it off and equipping our nurse managers with asking the questions. Two people could want to go to the same exact career path, but for far different reasons. So their trajectory to get there may look different and unique. And I think those questions behind that help us to feel, for bedside nurses to feel like we're investing in them as individuals. They're not just a massive workforce, that we care about them. And then opening up careers, like Aman mentioned, we have the traditional roles of people becoming managers and directors, but we have lots of opportunity for advancement in education that's required. We have a whole new workforce. So, but typically we have nurse educators at the bedside, maybe clinical specialists, but they don't have an opportunity so much to advance to higher levels, that maybe they do partnerships, again, with schools of nursing, or do some national symposiums, but to offer that as well. And then relook at, many institutions have clinical ladders, which are designed for recognition of nurses excelling at the bedside. But it's important to pull those out and make sure that those ladders represent the work of the nurse today and how we want advancement. And then I would just say, finally, because it's something that we are really passionate about here, is to make sure that, as far as even the scheduling piece goes of nurses and flexibility part, is that too can look different for different people. So there's one, aspect, you're right, of the 12-hour shifts that a lot of people don't, but people that do travel to work may want a consolidated time of 3 12s, but they also may not want 3 12-hour shifts at the bedside. In order to sustain them, what if we have a lot of people including us, have virtual centers that do virtual ICU and acute care. What if you did 2 shifts of work at the bedside and then had 1 shift in a virtual environment, or doing virtual phone calls or discharge planning? So to say even if you do have one particular role, it's not the only role you're doing right then, and it's supported within your work time. And we actually talk about how stressful it is to be a bedside nurse. No matter if you're in an intensive care unit or an emergency center or in a clinic, it is hard work. And you have to be, critical of thinking all the time, and it's a lot of stress. So it would be great for us as leaders to acknowledge that and to say, is your shifts are going to have a different cadence. So we retain you for the long haul and not just, have your productive hours right now. I think there's a lot of opportunities to do it differently.
Yeah, those are all great points. And I'd actually like to get into the workload distribution and creative solutions for that. And also, how to assist nurses with stress more as we move along. So thank you for raising those points. Sue, how do you approach career planning? First of all, address any points you want to, please.
Sure.
And then can you talk about how you are approaching career planning and cross-training?
I think, Gail, you made some excellent points within that. And I think, it's a paradigm shift, right? So generationally, they are not looking to stay within the clinical care environment or the same clinical care environment for long stretches of time. So as leaders, we need to be mindful of that. And so I think our nurse directors or nurse managers play a really critical role in understanding kind of what is the trajectory that a nurse wants when they first start within the organization. And so I think as a new graduate, there are many opportunities within the unit level in which they can acquire different skills. And depending on what their future track is, whether it is leadership, there's ways to support them within the environment they're in to achieve those things. So I know you mentioned the clinical ladder or clinical recognition program, which is something that we have here, and that really recognizes a nurse's skill acquisition. So that's important that we talk to them early on about what that might look like for them and if that's something that they want to aspire to. But there's other roles as well that I think help to build different qualities within nurses, and that could be like the resource nurse role where they're taking on additional responsibility, being able to kind of see the larger picture on the unit. There's also precepting, which we know is an important aspect of onboarding new staff and bringing new people into the environment. And there's lots of skills that go along with that. Additionally, at MGH, we have a role called the attending nurse role. And this is a role that is there to support the clinical nurses at the bedside. And it's a role in which the nurse really looks at the stay of the patient versus just the day of the patient. And it's really important because as nurses transition to working, 12-hour shifts, and the continuity isn't as great as it used to be when we had different shift work. This attending nurse really helps to support an understanding of the patient's trajectory. What are their needs at discharge? Are there barriers to discharge? And they can really help with throughput and length of stay. And that's really helpful to the support of the nurse who's taking care of the patients clinically. What this helps to do is it helps to build additional skills within the workforce. And so I think it's important for our nurse directors and nurse managers to identify within those individuals those that are ready to take on these additional roles. So there's lots that can be done kind of early on in a nurse's career so that we can continue to build and get them ready for the next career move or career advancement that they would like to make. I think we learned a lot through COVID. Certainly here at MGH, we did a lot between having nurses from our general care units move up to support ICUs as general nurse extenders, as well as ambulatory nurses coming into our general care inpatient units. And what that really did was expose them to a new clinical care environment. And so I think we need to look to the future to say, like, okay, how can we do that more? Trying to give more shadow experiences or opportunities for nurses to see different clinical areas. So while it's not completely embedded in our process now, it's something that we're working towards, because as Gail mentions, it's very stressful on our inpatient units. We need ways to ensure that we're creating opportunities to kind of meet the needs of our nurses, whether that be on an inpatient unit or whether there be some other opportunity. But there's lots that they can do within MGH certainly, and comparatively to other hospitals, that we want to make sure that we're keeping them there so that they're aware of what those opportunities are. So goal setting is important, but it's not just the only way that we need to do that.
Ernie, can you pick up on the career planning and cross-training, and is there anything that you would advise nurses to do in sort of being proactive about their careers and how they talk to their institutions about their goals?
Absolutely. I would add to what both Suzanne and Gail has said, and also flip the coin a little bit and say that it's not only from the management or leadership side to see that, but I would also put the onus on the nurse, him or herself as well, to, it's a partnership that they should be entering. And so if I, as a nurse, came to my nurse manager and said, I'd like to consider maybe the leadership track, well, then I would expect that manager to either find courses or something related to leadership that would help me to get a good foundation, or even you as a nurse, sit down, have that conversation with that manager and say, do you think this is a good course for me in my future transition into the leadership and management role? So we can plan things out, and that way it's a great way to help mentor. And as I said, it's a two-way journey, if you will, that both the onus is on both of the participants there. And for the manager or the leader, I would encourage them to give good, honest feedback. So that that person is once they do start their leadership skills or whatever, they can look back and know that this is somebody that I can count on and reliable for a mentor when I have questions or problems or whatever. I know that this person has my back and can do that. So that would be what I would certainly think needs to happen, that it is a two-way street, not just a one-way street, and all the encouragement that they could have, and being honest. I mean, in some cases, that nurse may not be ready for that just yet, and point that out and give them some things to work towards that would say, okay, now you are ready to go down this trajectory. That to me would mean a lot if I were a nurse and was told that, as opposed to trying to find ways perhaps to either stifle or do the advancement, but I'm not quite ready to start that process.
Thank you. I'd like to, you all mentioned flexible scheduling a bit. I'd like to touch on a little bit and then move into talking about the tasks of the bedside nurse and reorganizing how work is done. So first, Iman, can I just ask you to quickly sort of sketch out what you see about how well or not well hospitals and health systems are instituting flexible scheduling, and is it increasing retention?
Yeah, absolutely. So I mentioned earlier, the top reason why nurses are leaving a certain role or a certain employer is because of career advancement. And the second most common reason is flexible scheduling. Mm-hmm. We see that all the time, where nurses choose a job that has a schedule that works better for them, even if the other hospital is giving them more compensation, right? So sometimes scheduling can even trump compensation in many instances too. So essentially what we're seeing is that more and more hospitals are realizing that the days of only having full-time 3 days a week, 312s, right, are over. They've sort of ended pre-pandemic, right? And we now have five generations in the nursing workforce, which was mentioned earlier. They all have very different needs. You have nurses that are taking care of children. You have nurses that are taking care of their older parents. And as they're going through life, their needs are changing. And then frankly, overall, the job has gotten harder, right? So essentially what we're seeing is that the teams that are effectively providing a menu of scheduling options are able to retain more. What I mean by that, by the menu of options, is that sure, you still have the full-time, 312s, but there's also a weekend shift option. There's an 8-hour option. There's a 4-hour option. There's self-scheduling as well that supports all of that. There's also expansions of float pools, expansions of the creation of internal travel groups, which essentially is giving the nurse more pay in exchange for flexibility to float across many units or across even many locations. So really, by providing this menu of options and scheduling, hospitals are able to meet nurses where they are, and it's helping both hiring and retention.
So Gail, Sue, and Ernest, I'd like you to pick up on this, but I'd like to share an audience question. One questioner notes that during the pandemic, nurses were forced to retire rather than offering a 4-hour shift. So that, which I think sort of captures the tension between what the institution thinks it needs, what the nurse thinks she can do, but it ends up, nurses left. So Sue, can you start off and when you talk about flexible scheduling, can you talk about that tension?
Sure. I mean, I think you do need to be able to offer varying shifts. And I think those that could do a 4-hour shift, there's room for them within the environment to do that. And I think we have to be open to that. We don't just have 12-hour shifts here at MGH. We have the flexible scheduling. We also are able to do like long weeks and short weeks. So if there's something that you may need in a particular week, we can adjust your schedule to make that work. I think Iman touched on the flexibility of having a scheduling process that might be a self-scheduling process, but it really is important that it's a nurse-driven scheduling process. So we really encourage our nurses on their units to develop unit-based councils or scheduling councils to really look at how do they want to lay out the time plan or the schedule for their unit, what's important to them. And that could vary unit to unit. It's not one size fits all, but really empowering them to be active in what those decisions need to be. And I can give you an example. There's one unit, it's one of our ICUs actually, they have a points and reward system. So they're able to then choose kind of what is important to them and use those points towards it. So it might be to work one less weekend. That might be important to me, but working one less holiday might be important to you. And so they really try to balance the needs of the individuals with the needs of the unit, of course, and staffing it appropriately. But giving them and empowering them to make those decisions at the unit level is something that is extremely important. It helps them to feel empowered and valued. And I think it really brings forward the best product that helps with drives nurse satisfaction.
Thanks. Gail?
Yeah, I think all those points are great. And certainly everybody, I think, is moving fast forward towards that flexibility. I think we've heard loud and clear. I think the balance was for us why we, I think, shifted to those 12 hours is we know that handoffs of patient information can be a challenging time. And so I think leaders probably went to that because the consolidated time at that point worked for nurses, but also is those handoffs were reduced. So we have to make sure our patients are still at the center and that we take good care of them. But I think the embedding of technology to help support that handoff, certainly we all have electronic medical records, and finding information has been a challenge for nursing within that record. And so we have to partner with our technology folks in our online medical record platforms in order that nurses can see quickly the information they need to take care of their patient. So if we hand off care, there's no disruption in that patient's care. So I think that that's important. And then, nursing is rules-based. And so to say the rule is you must work 12 hours is, I think we're moving away from that fast, which is great. And then really, again, utilizing technology platforms so nurses can see scheduling and make adjustments from wherever they are. They don't have to be in the walls of their unit to make adjustments or to trade with somebody, is that they should be able to be anywhere and pull it up on their phone because they had something happen in their life and that they're able to adjust their schedules. Again, just like Suzanne's mentioned, if it's a reasonable request, why does a leader have to be involved with that? Treating nurses like professionals, that they can have ease of technology in order to adjust schedules to meet their family needs. And I think just lastly is, I think as leaders, as we know our staff well, is as they enter a different phase of their life, say they're having children or heading towards retirement, is during that career planning time, maybe mentioning just, upfront talking about, do you need changes in your current scheduling? What does that look like? You may not know now, but just to be very open-minded that we're here to listen and help support you through that next phase of your life. I think that would help.
Ernie,
Yep.
Pick up on any of those points. What I'd like to do after that is have you transition us into a back to the bedside nurse and talk about how work is distributed, how you have good lines of communication, and figure out when your nurses are being overburdened from EHR records, et cetera. They're duplicating documentation, chasing after meds. So please, if you have anything you want to add on flexible scheduling, but then I'd love it if you'd set up on the workload of.
Sure. So with regards to flexible scheduling, I very much agree with what the panelists have talked about. I'd also like to add that it's amazing that what Iman is talking about is reflective of a survey and also a workforce task force that the American Nurses Association and a couple of other nursing organizations are working on as well. And like what she pointed out, compensation is near the bottom. You would think that it would be at the top, but it's near the bottom of the priorities. And flexible scheduling is number 3 in the list. This is a great way to bring back the retired nurse. If you have a flexibility of 4 hours, what a unit could do is just take a look at, okay, when do we need nursing care the most? Depending on the type of unit that you're on, it could be that it's mid-morning, it could be it's maybe early noon or early afternoon or whatever. And I'm sure there are millions of retired nurses who would love to come back and just do 4 hours or 6 hours or so, or split an 8-hour shift with another retired nurse that would be able to help on the unit. And as a result of that, they get their, still get to keep their skills up. The unit's needs are met, and there seems to be less stress, if you will, within the work environment to get things going that way. And with that, I'll transition over to the workload, because I think that leads right into that. Obviously, we have all heard of and read about what it's like to be a nurse at the bedside right now. With the shortage, maybe call up to staffing and ask for for more help, and you're told we don't have anyone that we can send you. So we divide up the other patients that perhaps one or two nurses that could have helped to support that need. So that means now that a nurse may be taking care of 8 or 10 patients, or in some cases even more. And as a result, they're not able to do what it is that we do as nurses, which is to be there at the bedside, because now you're also with the further constraint of, always, going back to the electronic medical record to either check or uncheck something that required that you have to do that. Otherwise, you perhaps may wind up getting dinged, because it wasn't done. If it wasn't checked, it wasn't done. So that puts a lot more pressure there as well. And then the next shift comes in and they also request additional help, and they're told the same thing. So it becomes more of an expectation that you would do that. And we need to begin to address that and look at, okay, what are some things that we can do to perhaps offset the heavy load that the nurse may be encountering. I believe it was Gail who mentioned at the very beginning that looking at other forms of care, like maybe team nursing, where what are some things that other people within the healthcare profession can do that are that nurses can let go. If you have assisted personnel that could do your vital signs, or if you've got LPNs that could do medications. I'm going back to the old team style of nursing that that I was familiar with when I first got out of nursing school, but it worked to be able to do that. And even when it comes down to preparing discharge planning, why does the nurse have to do that? Why not get the social worker to to oversee that, and you work together to ensure that all the needs are met and things are in place. But it's not the nurse who's busy checking on this and checking on that or whatever. It's someone else's responsibility to report back to that, so we can help reduce the load and the stress that the nurse is encountering or feel that they are encountering, and so that at the end of the day, when they do go home, they feel that they did make a difference, and not that it was just a big whirlwind and they can't remember, did I do this or did I not do this, and not able to really have that downtime that they should be having if they're still reflecting back on their workday once they get home. That's not good for them either. They need to, once you leave that institution, your mind should be free of that work environment. It should be that I made a difference today, and if I'm off, then fine. And if I report back to work tomorrow, I'm ready to make a difference the next day as well.
So we have about 8 or 9 minutes left. So Sue and Gail and Iman, I'm going to come to you on a couple points. I want to mention an audience question, and I think it's going to resonate with the panel, which is that when you're talking about workload or flexible scheduling and you are a nurse, sometimes they feel that non-nursing administrators are obstacles and they have trouble communicating with them or getting a good receptive audience. And they're asking, do you have tips for them? And I'm sure that institutionally you can share how you are overcoming these issues to help with workload issues, get flexible scheduling implemented in an effective way. Can you share, Gail, can you start? And then I'll go to Sue and then talk to Iman.
Sure. Well, I think that as nursing leaders, you have to be able to speak to other administrators. But I believe now, again, more than ever, is that people have seen the value in the nurse and the value in retention of that nurse. Not only from filling a slot, but also as their career progresses, their expertise, and so that's seen as high value, whether you're a nurse administrator or just a regular administrator. So I think if they typically here at Houston Methodist, other administrators will look to us as nursing leaders to say, well, how can we keep our nurses? And so if you can show that you're implementing programs such as flexibility, and you will be able to, over time, keep nurses here within the walls of Houston Methodist, people see even the dollar value of that, of not having to recruit, not having to retrain, and certainly the quality of care aspect. That, of course, is a huge component to who we are, is we want to have high quality of care. And everyone knows that the nurse is central to that effort. So if you can show that you are, making strides to keeping your care quality high or improving it, I think that's incumbent upon us as nursing leaders to show if we try different programs, we're able to ensure that quality of care part plus that retention piece. You do have to be honest with those administrators and say there's no secret sauce right now, that we're in a very different environment, as Liz mentioned right out of the gate, and Aman, we're 1 million nurses short. So there's a lot of people vying for the same nurses. So we have to try strategies. Some will work very successfully and will keep, but others we will try. If it doesn't have value, then we have to get rid of it and keep going. And hopefully you can develop strong partnership with your other leaders in order to help on that journey. But clearly communicating kind of the state of nationally nursing right now to your peers, your boards, is really important as they partner with you on that journey.
Sue?
Yeah, I would just add to that, staffing and workload are critical to nurse satisfaction. And so one of the ways that we make sure that we're, advocating for the right resources is using our acuity and workload tool to really kind of quantify what's happening at the bedside to advocate for these resources. And it's one way because it's data that helps to speak to those in finance that really showcases what is the work of the nurse at the bedside. This has really been complicated over the last couple of years with not having as much assistive support personnel. So not having PCAs or others within the patient care environment to support care. So it's really critical that we're able to quantify what the needs are of our nurses at the bedside. One recent strategy that we've done here at MGH is to really look at, we have agency nurses to support some of the areas that we have vacancies, but we're looking to really onboard and hire more new graduate nurses than we ever have before, and doing it in a way that we're over hiring to kind of anticipate what we might have for turnover. And this is kind of one way for us to get ahead of the curve. And we think it's been effective so far. In August, we brought on board about 250 new graduate nurses. Huge lift for our nurses at the bedside, but they have been a tremendous addition to our nursing teams. And we think it's a strategy that might help us as we work towards the future and trying to just maintain a steady nursing workforce at the bedside.
Iman, can you add before I move to final thoughts, can you just add your insights on how you make the case internally to the finance people, to the CEOs, COOs, on why these programs are important to support nurses, support flexible scheduling, et cetera?
Yeah, absolutely. So probably the relationship between the nursing leadership and the finance leadership is probably one of the most important relationships going forward. Putting together a very robust business case or return on investment for these initiatives is critical, and that has to happen in partnership, because it's the finance team that can do the modeling and so on, right, on behalf of the nursing leaders. And so to Gail's point, there is a dollar value associated with nurse turnover, of replacing a nurse, of having a vacancy. And these programs that we're proposing, whether it's flexible scheduling or a new career advancement program or whatever it is, ideally are budget neutral. They pay for themselves because they're offsetting the cost of turnover. And that putting together that case usually makes the decision making far easier, particularly between nursing and finance.
Thank you. I'd like to ask for final thoughts from all of you. Ernest, can you talk about what you think are some of the most important points we should remember?
I think some of the most important points that we talked about is it just winds down to communications at all level. Two ways of communication. Listen to the nurse at the bedside. What it is that they want, what they need, and actively listen to the response that you're getting. And try to incorporate those where you can, but even if you can't, at least communicate back that we tried this, or we hear you and here's why it will or will not work, perhaps, but at least let them know that you are interested in hearing what they have to say, and if they have ideas, perhaps we're willing to give those a try as well. but communication is so much the key to all of this. It's the best way to show the nurses that you are valued and we value you, and and we want to hear more from you as to how we can continue to to show that or enact that that process.
Thank you. Sue?
So I think this is a pivotal time for us. I think, what we've done in the past, we have to change for the future. So, something that worked 20 years ago isn't working now. We need to look at care delivery redesign, and that's going to take a lot of work for us to do that, but it's something that we need to do given the current constraints. We learned a lot during the pandemic on ways that we needed to do things differently. And so I think sometimes out of chaos comes order. It's kind of chaos theory. And I think it's really going to push us to look at things differently as we move into the future. Not, there's just constraints that are within our environments that are going to force us to do that, but it's a time for nursing to really reshape the future. And I think it's a pivotal time.
Thank you. Iman?
Yeah, last thing I'll say is that, we're all operating in a very dynamic environment with, the factors are changing all around us in terms of the market forces as well. And so I'm very hopeful for the future. I mean, as Gail mentioned, the attention on nursing is very high right now across the C-suite as well as media and so on. And so this is a real opportunity to really push some strategies and tactics forward that help strengthen the U.S. nursing workforce.
Thank you all for an extraordinary conversation. Obviously, the durability of our healthcare system rests almost entirely on our nursing workforce. We have to get this right. And it's been 20 years at least that these problems have been boiling up. And I think finally it looks like they're getting the attention they deserve. And I really appreciate our panelists for pointing the way to some of the solutions that really may help take us forward. Thank you so much.
Thank you.